Good morning, everybody. Welcome to Grand Rounds. For those of you that are here and those of you on Zoom and at distant sites, welcome. Before I introduce the topic and our speakers, I wanted to go to a land acknowledgement. We're gathered and are grateful to live and work and play on the traditional and ancestral and unceded territory of the Coast Salish people. I think there'll be a land acknowledgement with the presentation. The Division of Geriatrics is presenting rounds today. Two newer members, Dr. Sohi and Dr. Lester, and the topic you can see, approach to perioperative care in the older adult. Doctors.
All right, so introductions. I'm Dr. Sohi Gurmeet. I'm one of the new geriatricians that started practice earlier this summer. And my focus is mostly acute geriatrics and perioperative medicine in geriatrics.
Yeah, and I'm Robynn, as all of you in this room know, Robynn Lester. I have been a geriatrician, this is my second year, and I also have an interest in perioperative care and had a great opportunity to go to London last year for a month to train with them.
So over the course of the next 45 minutes or so, we'll go over the utility of the comprehensive geriatric assessment in the perioperative setting. We'll look at the risk stratification methods that we use during our assessments, recognize the importance of frailty and functional status when making perioperative decisions, addressing the cognitive aspects of perioperative care, and then looking at decision-making, informed consent, and capacity, as well as planning for end-of-life care in that environment. Before we begin further, we would like to acknowledge that we are gathered today here on the traditional territories of the Musqueam, Squamish, and the Tsleil-Waututh peoples. So perioperative, this is a great quote from Rohaki, which just emphasizes that periop care of the patient is best accomplished by combining not only the science of medicine, but the old-fashioned art of medicine. We all are familiar with a lot of the risk stratification tools that we use in the perioperative setting, but keeping in mind these are it's a single data point in a combination of factors, and it should not be a substitute for our clinical judgment and evaluation. So we're going to work through a case that we might typically see as geriatricians and incorporate the various objectives and principles that I highlighted just earlier. So we have a patient, Jane. She's an 83-year-old female with a history of type 2 diabetes, hypertension, and osteoarthritis. She lives at home, and she's coming up for a right total knee replacement. She doesn't have any history of coronary artery disease, chronic kidney disease, strokes, or heart failure, and her A1C, as you can see, is pretty well controlled. At home, she's on metformin, some T3s due to pain, zopiclone, and atorvastatin. Her revised cardiac risk index is 0. Her preoperative NT-proBNP is 150. With an ASA class of 2. With this information, we might think that Jane is at a pretty low risk for postoperative complications. But over the course of the next 45 minutes, we'll determine, once geriatrics has taken a look at her, whether that truly is the case. So we'll start off with what is the comprehensive geriatric assessment. So those are the consults that we would see as geriatricians. They're usually done in person and total about an hour and a half. We usually have family members or collateral present to complete our history. And it's a multi-domain holistic approach that we take on as geriatricians, where we look at not only their medical issues, but we look at their physical health, the socioeconomic and environmental factors, their functional history, as well as their function as it relates to mobility and balance, their psychological and mental health, and then doing a polypharmacy or more thorough medication review. And based on looking at all of these various components of their health, we create a problem list and offer personalized care plans that then have interventions. So the comprehensive geriatric assessment is not only an assessment method, but it is also a means of intervention. So highlighting those various components of the CGA that I just mentioned, we have specific tools that we use to assess. So for example, if we have, for our cognitive piece, we'll do a cognitive test of choice, usually an MMSE or a MOCA. We'll look at their physical function by looking at tests such as the timed up and go or gait speed. We'll look at their nutrition through the mini nutritional assessment, the mental health through the geriatric depression scale, social health from the collateral or the patient's history, and then looking at their comorbidity and polypharmacy as we would in internal medicine. And then based on what we see, there's interventions that we can offer to try to optimize these various aspects of a patient's holistic health, whether it's, involving prehabilitation, which we'll talk about in a little bit, looking at dietary changes, therapy, pharmacological or otherwise for any mood issues, and then looking at deprescribing and optimizing any polypharmacy. And what we know about comprehensive geriatric assessments are that they're quite effective in the perioperative setting in improving patient outcomes. So based on a Cochrane review, we know that the involvement of geriatrics in completing the comprehensive geriatric assessment reduces discharge to a higher level of care and gets people back to their homes. We also know that it probably reduces post-op mortality in the orthopedic setting where it's patients with hip fractures. I will note that from the 7 studies that were included in this Cochrane review, only 2 of the studies had CGAs that were done pre-operatively, and the rest were with post-operative geriatrics involvement. And we also know that it improves outcomes when it comes to delirium post-operatively, which we'll chat about in a bit, length of stay, the loss of function or time to mobilization is minimized, there's improved pain control, and there's decreased cost to the system. There's various studies that have looked at these markers, which are cited in the corner below. So I'm going to switch gears and hand it over to Robynn to talk about frailty and function.
Hello, everyone. So I'll be talking about the frailty and functional piece. So to start off, what is frailty? Frailty is an age-related decline in the reserve across multiple physiological symptoms. And this makes someone more vulnerable to adverse outcomes when they're faced with a stressor. So it is more common to get frail as you get older, but age is not synonymous with frailty. There's a lot of other things at play, which I'll talk about in a little bit as well. The bottom graph here shows that based on functional status, if say someone who is independent gets say a minor stressor for someone like us, hopefully like a UTI, we should get back to where we were before. But if someone who is teetering on the dependent side of things, so they're needing more help with their IADLs, BADLs, if they get a UTI, they might have a very different outcome based on their frailty than one of us. So there's the frailty that's associated with the multiple different physiological symptoms, but it's not just that contributes to frailty. There's also the cognitive piece, the social aspect of frailty. We look at polypharmacy and the psychological aspect. So someone may not have a lot of comorbidities, but depending on their social isolation, their psychological state, they can still be frail. And when frailty is involved, we have syndromes or geriatric syndromes, essentially, that are the presentations of other illnesses. So for example, delirium and falls are things that will happen in someone who is frail when they are presenting with, say, a common medical illness, such as a UTI, which is why, say, someone who is older and frail comes to the emergency department with sepsis, they might not present with fever and chills like we would normally expect. They might come with just delirium, or they might come with just a fall. And that's why we need to really ask questions and figure out what's going on in the background. So why does frailty matter? So just over 20% of the world's population will be over 65 by 2050. And so that's double what it was in 2000. And not only that, but if you actually look at the number of populations over the years, so from 2000, this is beyond kind of close to 2020, the number of operations in children in those 15 to 59 has stayed roughly the same. But when you actually look at the over 75 category up here and the 60 to 74 category, the number of operations is increasing substantially. And that's why we should care about frailty. Frailty is very prevalent in surgical populations, and those going for surgery will have a higher frailty on average than community-based counterparts. And we know that frailty is better than age in predicting post-operative outcomes. So there have been some studies in the past that look, say, comparing people over 65 with those under 65 and the outcomes, but you really can't compare those two. They're just completely different. It's more about the frailty aspect. So we know that those going for hip fracture over 65, 50% of them, or going for hip fracture surgery, 50% of them are frail. Same with the vascular population. Trauma, there's a very high percentage of frailty in these populations. And if we look at, say, a 70-year-old going for an elective cancer surgery, 50% of those will be frail. And if they're going for an elective non-cancer surgery, it's a little bit lower at 30% compared to someone who's 70 in the community not going for any surgery. And this obviously depends on the type of surgery and the urgency of surgery as well. So, for example, if someone is going for a prostatectomy for a surgically amenable prostate cancer, they might not have the same symptom burden as someone with colon cancer and therefore might not have the same frailty. So it does depend on the type of surgery they are going to have. Frailty is an independent risk factor for poor surgical outcomes. So surgery is a stressor for anyone, but really no procedure is low risk when frailty is present. So as we can see from here, there's a very high percentage or very high risk of death and major morbidity. Post-operative complications, including post-operative delirium, are very high, and prolonged length of stay. But even beyond that, often, we think about death, and the population thinks about death as one of the worst things that could happen after a surgery. But there's also the functional aspect. So a lot of people would say, well, being institutionalized and not being able to go home is just as bad or worse than death, in my opinion. So everyone has different thoughts on what would be a poor surgical outcome. But we know that the odds ratio for long-term care and functional decline after surgery in frail individuals is very high. And this is true for both elective and emergency surgeries. So what do we do? How do we measure frailty? So the comprehensive geriatric assessment is the gold standard to measure frailty by way of all the questions we ask and the assessment that we do. There are other proxies that we can use, including gait speed and the timed up and go test, greater than 10 seconds, which we do in our clinics. We also look at things like, are they able to get out of a chair without using their arms? Can they do a 5-time chair sit to stand? Grip strength is something that is used in research based on one of the frailty criteria, the phenotype frailty scale. However, we don't routinely measure this in clinic. But frailty tools are another way we measure frailty. And although these are not validated yet in the pre-op setting, there's a lot of research going into this. And in Toronto at St. Mike's, they are looking at the Prisma 7 in terms of the pre-op setting as well. But the clinical frailty scale is the one that shows a lot of promise in this setting. And it was created by a Canadian in Nova Scotia. What's nice about the clinical frailty scale is it's easy and it's quick. It was actually designed to be used by geriatricians, but it's been validated to correlate with mortality and institutionalization, even when used by junior residents and medical students. So it predicts mortality, long-term care, but we can't use it in those less than 65. We could, but it's not validated. And what's nice about the clinical frailty scale is that the CFS 5, 6, and 7 actually correlate with mild dementia, moderate dementia, and severe dementia. So mild frailty, if you had mild dementia, you would kind of be in that category. And when we do our clinical assessments, we use other tools as well to predict poor surgical outcomes. So Robinson et al. And then Macari kind of use the same measures of frailty, and they created this tool to help you assess if someone is frail and what their discharge outcomes may be. It looks at things like the tug test, the functional status, the cognition, how many comorbidities they have, looks at things like anemia and nutrition and falls as well. Now, when I get these numbers, I always, like Gurmeet was saying at the very beginning, use these as a guide. So I try not to quote to my patients, you have a 33% chance of post-op complications, because that really doesn't mean a lot to these patients. I'll really try to phrase it as a low risk or moderate risk or high risk. And also these are just a guide. So say if this is a very low risk of post-op complications, but I think the patient based on the CGA has a higher risk, I'm not going to quote these numbers to them. So these are a guide, but they can be helpful when there's uncertainty. And then part of addressing frailty is prehabilitation. So if we have the opportunity to see patients prior to going for surgery, then we can intervene with prehabilitation. And what this means is it's about enhancing a patient's functional capacity before surgery in the aim to improve postoperative outcomes. There's three aspects. One is exercise or physical care, one is nutritional support, and one is psychological support. So the exercise piece, why do we care about this? Surgery itself is a huge stressor. It causes inflammation. You're often in bed for at least 24 hours not moving. And we know that the longer that even healthy older adults are confined to bed, they're going to lose muscle mass. And we want to try to increase that or stabilize it before surgery. So the most evidence has been on multimodal programs where they do strength training, aerobic exercise, about 3 times a week and at least 2 weeks pre-surgery. And this has been the most effective. However, these studies have all been largely in non-frail older adults. It has been shown to decrease complication rates, increase functional recovery. And I'll talk about this a little bit, but they often use a 6-minute walk test as a measure of recovery after surgery to figure out if this has been significant, which correlates with a change of 20 to 25 meters. And I'll talk about that in our older population and if that's relevant. Now, Dan McIsaac in Ontario is doing a lot more studies in the frail population, which is fantastic. These are 2 studies about prehabilitation in frail older adults. The one up here, the JAMA one, was actually comparing prehabilitation with post-op rehab, so not necessarily the best control. And then this one with Dan McIsaac's group was looking at a home-based exercise program, and both also focused on nutrition information as well. Now, all of these patients were at least mildly frail. They were over 65. But really, in both of these randomized controlled trials, there was no difference in post-op complications, readmission rates, length of stay, or the 6-minute walk test. And so why might that be? Because you would think that prehabilitation, if it's working for these non-frail adults, it should work in frail older adults as well. But in our frail older adults, it might not be appropriate to be using the same measures of recovery. So for example, 20 to 25 meters is a lot for a lot of our frail population. And so expecting them to improve by 20 to 25 meters in a 6-minute walk test just might not be feasible. I think also issues in study design, also adherence. But the other aspect of this, and really what they talk about a lot in London when I was there, is that what is the role of prehabilitation in these frail older adults without the comprehensive geriatric assessment part of it? So is it enough to do the exercise and the nutrition, or do you really need that comprehensive approach in these frail older adults to have the same outcome? Nutrition is another really important part of prehabilitation. The minimum recommended protein intake for all older adults is not commonly met by even those in the community. And then in cancer patients, we recommend that they have even more protein. This is a study that was done not just in frail older adults, but it actually showed that they took a population of older adults who weren't necessarily malnourished based on the mini nutritional assessment, but they gave them boost, essentially, protein supplementation, and they found that those who had the protein supplementation had less total number of complications, less wound infections. And so the practice that I've adopted from Camilla Wong in Ontario is recommending increased protein to most patients in going for an upcoming surgery, especially if it's a cancer surgery. Trying to get them to eat at least 20 grams of extra protein a day, which is equivalent to like one egg, whether they want to do protein powder, just to try to maintain that muscle mass and prevent them from losing more weight. And then the other thing is we want to minimize the amount of fasting, the duration of fasting, because as we know, just not eating will make anyone hangry and upset, but in someone who's an older, frail adult, that can also precipitate delirium. And this goes with the ERAS protocol as well. And we're very good at this as an outpatient. Anesthesia and surgery is great at educating patients on this, where they aren't necessarily fasting, since after midnight, they're allowed to drink clear fluids up until a certain point before surgery. But we're not so good at this as an inpatient because of multiple factors, but it's often NPO at midnight. And then the surgeries get delayed, and then they're NPO for 24 hours, and it gets very hard for our older population. I'm going to hand over to Gurmeet for the cognition portion.
So we know that cognition is a big issue in our older adult population. The prevalence of dementia just generally in the Canadian population is around 8.4% in those over 65. And then as we get older, that prevalence also increases to about a quarter of people over 85 having dementia. Some studies have looked at the prevalence of cognitive impairment in the preoperative population, and it is quite large. This particular study involved both mild cognitive impairment diagnoses as well as dementia, and they found during that systematic review that the prevalence ranged from 37 to 50% in surgical patients for non-cardiac surgery or emergency surgery, which is a pretty high level. And then we also know, based off multiple studies, that preoperative cognitive impairment in older surgical patients significantly increases the risk then of postoperative delirium, 1-year mortality, especially if they're more in that dementia subset, discharge to assisted or higher level of care, readmission, and overall postoperative complications. So us as geriatricians, when we do these preoperative assessments in our clinic, we will also always do cognitive screening as part of that assessment, determine their baseline. So most of the time in our comprehensive geriatric assessments, we'll do, based on the patient's presentation, a MOCA or a MMSE based on the extent of functional decline. But the mini cog is also a tool that has been studied, and a recent study in 2022 by the Tawari group found that doing a preoperative mini cog in clinic and then the day of, people who scored less than 2 were strongly associated to develop postoperative delirium based on the confusion assessment method. And why that's helpful for our group is we have the liberty during our comprehensive geriatric assessments to take the time to do these full cognitive assessments, but the mini cog is something that can be done within minutes. It's really a 2-step test. You give 3 words for the patient to remember, you get them to draw a clock, and then you ask them to remember what those 3 words are, and that's the extent of the test. So it takes literally a couple of minutes, and based on that score, it gives us information as to what their risk of postoperative delirium may be. It also gives us a baseline to see if there is postoperative delirium, and then cognitive impairment. We can compare what their pre-op MOCA or mini cog was and compare it to postoperative measures. So why do we care about postoperative delirium? First, knowing who gets postoperative delirium is helpful. So this Bramley review actually was an umbrella review of multiple systematic reviews, and they found these common factors to be involved in contributing to postoperative delirium, though we know just generally from our medical practice that there are a lot of variables that will contribute to delirium. So age and pre-existing cognitive impairment are some of the big ones. Also, patients who are from long-term care or who have cerebral vascular disease or end-stage renal disease that are at higher risk, as well as malnutrition. Usually the low albumin is a substitute for that, having a higher ASA score, or requiring an intraoperative blood transfusion. Again, postoperative delirium is associated with higher mortality, long-standing cognitive decline. So Sharon Inoue, who is a geriatrician in the States that does a lot of research on delirium, recently just put out a paper that looked at the cognitive effects of postoperative delirium and followed patients over a span of 6 years. And they find that the patients who had postoperative delirium do have long-standing changes to their cognition and acquire more long-standing cognitive impairment from that. There's also the loss of independence and autonomy, increased length of stay, and again, increased cost. So postoperative delirium is something that we can screen for by looking at pre-existing cognitive impairment. And we can also apply the lens of prehabilitation to this domain as well. So this was a study that looked at the Luminosity computer program in stimulating kind of cognition prior to surgery. And it was a randomized control trial looking at a small population size of about 250 patients who didn't have cognitive impairment or depression at baseline, who were going for major non-cardiac surgery. And the intervention lowered delirium risk in patients who are at least minimally compliant with the exercises. Though the signal was weak, and so further studies are required to look at whether there's prehab tools that can be utilized in that pre-op setting. What we do know, though, is given that there's so many risk factors to the incidence of postoperative delirium, looking at a multi-component targeted intervention in delirium prevention is where we see the most success. So the Hospital Elder Life program is, again, something that's been widely used in various inpatient settings. And over the kind of span of perioperative settings, acute medical inpatient ward settings, we know that by applying these concepts, people have a reduced incidence of delirium as well as falls, and a trend towards decreasing length of stay and preventing institutionalization. And what the program looks at is providing reorientation, therapeutic activities, as is often done on our ACE units here, enhancing sleep and normalization of the sleep schedule, early mobilization, so involving physiotherapy early for these patients, ensuring that vision and hearing is optimized, and then looking at making sure patients are hydrated and getting adequate nutrition. So I feel like a lot of the time on CTU or in our post-op surgical patients, we often will look at delirium, do the dimmers, and then address the dimmers approach and leave it at that. But often things like sensory optimization, nutrition, hydration, and physical activity get neglected. And so that's areas where we as a group can intervene. And then also looking at pain management and using psychoactive medications judiciously. So I always recommend that the non-pharmacological interventions where the evidence lies for there to be benefit should be optimized before we start pulling out the loxapines and the quetiapines and trying to manage delirium. And then we also know, again, early involvement of geriatric medicine and the opportunity for us to perform the comprehensive geriatric assessment reduces the post-operative delirium incidence. And this is a Cochrane review looking, again, at surgical services, mostly driven, again, by the orthopedic surgery environment. So looking at decision-making then, we try to use a shared decision-making approach with our patients, using language that patients will understand. So as Robynn mentioned earlier, death isn't the only negative outcome from a surgery. So oftentimes these discussions will tie in with advanced care planning and goals of care discussions, and we get a better understanding of what the patient's values are. So for example, I saw a periop patient yesterday with colon cancer, and this is a cancer that could possibly be surgically treated, but he's at moderate risk of functional decline, of cognitive impairment. And for him, that's not an acceptable risk because that means his quality of life may diminish. And so he would rather go through medical management with PRN transfusions for his anemia rather than take the decline that could potentially come. And so having these discussions with each patient is important because each patient's value system and what good quality of life means for them matters. And also some patients may value prolonging life versus quality life or vice versa. And it's our role to understand that each individual's patient's circumstance and preference. Given that 30 to 50% of patients might have cognitive impairment prior to their surgery, it's important to ensure that they understand and are able to have capacity in that decision-making. And so the tool that we often use in our assessments is the 4C model. So appreciating if the patient understands the context of their situation, if they're able to weigh the choices, like whether they choose to go for surgery versus non-surgical management, and being able to then compare those potential consequences and then displaying consistency in that choice. So there's consistency both in terms of a temporal sense, but also if there's internal consistency with what they're saying. So sometimes we'll have patients that say, I would never want to, end up in long-term care or be dependent or not be able to recognize my family. They're at high risk of, post-operative functional decline or high risk of delirium. And then yet they still want to proceed with surgery. And so sometimes that will raise flags in terms of whether their expressed choices are if there's internal consistency with what they're saying and then their decisions. It needs to be individualized. So the level of cognitive impairment is important to assess, which is part of our assessment, the complexity of the situation, and always remembering that capacity is situation specific. So we don't ever say that people are not capable of overall making decisions. It's meant to be in the context of a very specific situation. And then during our pre-op assessments, as I mentioned, we will do goals of care discussions. As we know, when patients get hospitalized, both for acute medical issues or with surgeries, complications can happen and people can lose capacity during a post-operative delirium. And so having the goals of care discussions in the outpatient environment before there's any acute stressors with family present allows patients to have improved satisfaction or sense of satisfaction. They feel improved quality of life, and they feel that the care that they're getting is more consistent with their preferences. And then it's also shown to reduce life-sustaining measures near death and improved bereavement outcomes for family after death when death does arise. So this is the clinic that Robynn participated with in London, and they found that at least within their own internal patient database, after they do these assessments, about 15% of patients decide to not proceed with the initially proposed surgery, and 23% of their AAA population.
So getting back to our case of Jane. So Jane comes in for a preoperative geriatric assessment. And so we're going to look at the cognitive piece, the functional piece, nutrition, her comorbidities, and then her goals of care as well. So this is done in person with a family member present. So what we find out is that, so Jane is a retired accountant. She's had a few years of functional decline though. And this is largely from her daughter, who's the collateral history during our assessment. She drinks about 2 to 3 beers per day. And sometimes she actually forgets to eat. She's been forgetting to take her medications. And the daughter has some concerns about her getting lost while driving. She's had a previous CT head. She's had no previous strokes. And on cognitive testing in clinic, she doesn't score that well on her MMSE or her MOCA. She uses a four-wheeled walker, and she's had 4 falls in the last 3 months. When you assess her gait, she has slower gait speed. She's unable to get out of a chair without using her arms. She has quite poor balance, and she's quite thin as well. She's a BMI of 19. And then looking at her medication, so she takes zopiclone, which we know has risks of falls, delirium. Her HbA1c was only 5.7, but she's still on metformin, which could lead to falls and hypoglycemia. And then she's taking Tylenol 3s, which can also lead to constipation, increased delirium risk, and falls risk. She's had some weight loss over the last few years, and she's really only eating 1 meal per day. Otherwise, she'll drink beer, and she's just not that hungry. She doesn't do any regular physical activity, and she's only having a bowel movement every 3 days on average. So how does this change our overall assessment of Jane? So Jane is an 83-year-old female, possibly mild dementia. We need to do some more questioning and more assessments. She has hypertension, there's excess alcohol use, and she's from home with at least mild frailty, falls, and now she's pending this right total knee replacement. So from this assessment, knowing her cognitive impairment, we know that she's a high risk of postoperative delirium, and also from her alcohol use. And she's at risk of further cognitive decline after that as well. So we'll talk to her and her daughter about how important it is for the family to be in hospital to reorient her. We'll talk about her medications, which I'll mention below. We'll see if it's possible for her to wean her alcohol somewhat, and we'll talk about reorientation measures as well. And we'll also talk about follow-up in the future to reassess her cognition after surgery. We know that she's at a moderate risk of functional decline and complications. So she uses a 4-wheeled walker. She doesn't do any regular activity, but if we have enough time, this is an excellent time to do prehabilitation, whether that's giving her exercises to do at home or referring her to one of our physiotherapists to work on that and develop a program. We would talk to her about blister packing her medication so she's not forgetting them, getting rid of zopiclone, trying something else like melatonin, inquiring about her mood, and then, you know, talking about the Tylenol 3s and maybe just having some scheduled Tylenol there. I don't know what that is. I don't know. Okay, we're just going to keep going. So, and then we also know she's high risk of malnutrition. So she's really only eating 1 meal a day. Her BMI is on the low side. And then she's only having a bowel movement every 3 days, and she's taking Tylenol 3. So we got to get on top of that. So we would talk about giving her some regular laxatives, and could it be that her cognition is affecting her intake as well? And maybe she needs some regular meal delivery or some help with that prior to going for surgery. So what has been identified? So in terms of her goals, and is that someone like
on Zoom?
Zoom?
Yeah.
Okay.
Yeah.
If you could answer the phone or turn off your mic, that would be great. So goals and values. Are the falls that she's having actually because of her right knee pain, or is it other factors? Is she having some hypoglycemia? Is it the alcohol? So there's a lot of things we need to figure out. And then how much is that right knee pain affecting her quality of life? And how much would she be willing to sacrifice to have that pain be improved? And also setting realistic expectations. You know, she might not, you know, some people say, I want to walk without any gait aids. And it's like, well, that might not be realistic, but we can aim for something and set some reasonable goals for you. And then also talk to her about what would be unacceptable to Jane. And then a non-perioperative issue that we'll just flag for the future is also her driving safety and actually assessing that a bit further. In the post-operative state, geriatric medicine, we get involved for early prevention of delirium, ideally. And if there is delirium, we try to optimize things as best as we can using the HELP model, the Hospital Elder Life Program that Gurmeet mentioned earlier. We encourage them to get up, mobilize, do physiotherapy. We make sure they're not getting regular Gravol or Benadryl, and make sure that their pain is controlled, but also that they're not getting overdosed on their opioids. And then also nutrition, watching to make sure that they actually are eating and getting fluids appropriately. So how to get us involved? If you want to refer for a pre-op geriatric assessment, it's pretty easy in Cerner. You just type in geriatrics. And then there's the referral to outpatient rapid access geriatrics. There's one for St. Paul's, there's one for VGH, and there's one for UBC now as well. This pops up and you would say next available appointment. You would say which location you want it to go to. And then in the special instructions, you would say the reason for the referral. And if it is a pre-op assessment, we try to prioritize those to be seen in a timely manner. If you know the OR date, that's great. Put that in. If not, that's okay as well. In hospital, just call us, Jury Consults, and we talk frequently with the anesthetists in the hospital as well about high-risk patients that maybe we've seen pre-op that are in the PACU, also with the orthopedics team as well. But really, if you call us, we're here and we'd be happy to see these patients to try to prevent delirium down the road. Is that? Oh, yes. And then if a patient is being discharged, but would still benefit from outpatient geriatric follow-up, the same referral to outpatient works, and then we can see them for their assessment. So that's the end of our talk. We'd be happy to take any questions or comments. Oh goodness, the phone is that. Thank you very much.
Yes.
Thanks so much for the comprehensive review. I had a question about two questions. In your paper, you had mentioned Robinson and Macquarie using a frailty scale. What surgical population did you use them in?
Yeah.
And second question is, how do you stratify based on type of surgery? Because hip is very different from colon surgery, which is very different from Whipple surgery. And so how do you stratify based on the type of surgery? Because I imagine their risks are different as well.
Yeah, that's a very good question. So just to start with the latter in terms of the type of surgery. So any patient might be triaged through the system. So even someone going for a TURP might for some reason be referred to us as well. But in terms of the actual type of surgery. So in, let me go back to that actual slide. So in that Robinson et al. Criteria, it does talk about the type of surgery. Now they mainly categorize like a major vascular surgery as the ones that would be higher risk, because obviously those would be a higher risk for delirium. So sorry, not this one, but a different one. But you can categorize basically if they're going for like a major surgery, which is going to be multiple hours with potential lack of blood flow to the brain. So things like a major vascular surgery or a CABG, those things would be higher risk. Same with the duration of like a Whipple surgery versus say an arthroplasty. But there isn't actually say a tool that has been developed to categorize and risk stratify based on the type of surgery. It's still based on clinical gestalt. And sometimes what I'll do is if I'm really not sure, I will actually email the surgeon and say, like, how long would this surgery be? Or email the anesthetist and say, what kind of anesthesia would you be using? Because that also impacts the risks afterwards. And then the first question was about this scale. Yeah. So it was general surgery, including ortho patients in this population. Yeah. Yeah, I do use that. So what I find, so that one is good because it has the frailty aspect. So if your patient is over 65, it will automatically kind of pop out some of the risks of like institutionalization. But what I would caution is in the States, they include rehab facilities along with long-term care. So it might say a very high risk of going to facility, but that facility might not be what we'd consider long-term care. It might be a rehab facility. So I use that also. So whenever I'm seeing a pre-op patient, I'll use these risk tools to help, but still the comprehensive geriatric assessment is my overall measure of the mild, moderate, severe. The NISCIP is pretty good though. Yeah.
Any other questions? So I have two questions. You mentioned the frailty scale. But in this hospital, frailty is a large component of illness independent of age. So, and you were comparing frailty to 70-year-olds or whatever. So is there people use a frailty scale independent of age? But I know you're geriatric, so you don't, but do you use it, or do other people use it?
Yeah.
Yeah, I do. Sometimes I'll have patients that are less than 65,
Right.
and we will jokingly refer to like this is a 60-year-old going on 75, right? Based on their overall function. So sometimes we do see like even when I'm doing internal medicine and I see these patients, I might not use the CFS the same way, though it is somewhat of a guide, but I think looking at their functional history, their social history, if there are components of a 58-year-old who's having multiple falls or has alcohol-related cognitive impairment, I would label them or diagnose them with mild frailty or moderate frailty based on still a comprehensive geriatric assessment lens on those patients. Yeah.
Second question is there been any study of looking at a nurse that is by the individual patient nurse, so not in a hospitalized patient, to look at delirium, post-op delirium?
Yeah, so the HELP program actually is based on recruiting volunteers. So a lot of these studies have not volunteer nurses, like trained nurses, but they'll be volunteer bedside people that will kind of make sure those components of the HELP program are implemented. So they'll sit with patients and provide reorientation or engage in therapeutic activities with them. And that's how they've studied it, is with a robust volunteer program. Because we know realistically, based on our staffing, it's very difficult to have that level of nursing care. And so the evidence, at least where HELP is studied, is based with volunteers who then provide those interventions.
And then final question is, you see the geriatric population on the orthopedics. So are you looking at your interventions? I recognize most of the people here are acute and you don't see the pre-op, but are you looking at documenting your experience on the geriatric service right now? Or I'm sorry, on the orthopedic service?
Yeah, so we are looking at kind of starting some quality improvement studies. We eventually would like to kind of create a service where we are more involved in the ortho-urology service. We are quite involved now, but it would be a goal of ours to do quality improvement. And I know Gurmeet is... Could everybody mute their mics, please?
Thank you. At noon. I missed most of it though, but anyways. Thanks.
Yeah. Anyway, yes, that is the goal, to actually show that we're worthwhile and to actually figure out what the rates of delirium are before and kind of after our involvement, or patients that might be randomized to our involvement versus not. So it is to be decided.
Yeah, in the next year or so, I do plan on, my niche will be more peri-op QI, and in addition to like post-operative delirium and cognition, we're also going to be looking at least in the orthopedic population, rate of referral to a falls clinic or an osteoporosis clinic post, how many patients are being treated for their osteoporosis, because a lot of these patients are frail, they've had a fragility fracture from a standing height fall, and oftentimes without our involvement they won't be initiated on osteoporosis treatment, and then we'll come in with recurrent fractures or further falls. And so some of the measures that I hope to look at, though it's going to be a couple of years of a project, is looking at how our involvement changes that in terms of being on adequate osteoporosis treatment, adequate follow-up with the falls clinic, and then looking at cognition and kind of overall outcomes.
Dr. Chan.
So for the non-geriatricians who are going to have geriatric patients, which is the best measure to use? Is it the overall frailty score? Because obviously we're not going to be doing a tug test and a CAT score and a mini cog and a Charleston comorbidity. So
I'm obviously biased, but I think the best assessment would be collaborating with us as the geriatricians, because we know, like, I'll do internal medicine impact at VGH, and the lens that I apply when I'm doing that service based on or compared to when I do geriatrics, we just have more time and resources in our geriatrics to be able to look at these other aspects of care. And so I think collaborating with internal medicine and geriatrics to, if you see a patient who's going for surgery and you get the sense that they're not functioning as well, or there might be some cognition issues, having us involved to then complete that comprehensive geriatric assessment, I think gives the patient just a more thorough review of what their perioperative risks might look like and the opportunity for intervention on some of those risks. In terms of a single tool, it's hard to say because patients are so multimorbid and complex that they do need, or at least what we suggest and evidence suggests, is they do need that comprehensive review to improve their outcomes.
And one thing I would just add to that is often, say, if you're just looking at the clinical frailty scale and you ask the patient, oh, can you do your own bathing? Can you do your own toileting? And they're like, yes. And okay, that's great. But like, really what we take the time to do in our assessments is, well, when your father goes to the bathroom, do you need to cue him to wash his hands, how to wipe, all that kind of stuff? And so people have a very different sense of what independent means, and it takes kind of a comprehensive geriatric assessment to actually determine what their true functioning is.
Yeah, they've started looking at like people self-reporting their CFS. That's not validated. So looking at clinical, like really the CFS or these frailty tools are meant to be done by trained physicians. And so like Robynn says, there's a lot of, there is some variability in terms of the CFS, how one person might say they're very mildly frail and another might say that they're mildly frail. And so I think, I think having a trained physician that can tease out those aspects of what functional status looks like is important. And then as Robynn was saying, with the CFS, there is some correlation that mild frailty correlates with mild dementia, moderate frailty, moderate dementia, severe frailty, severe dementia. And so it might be a step towards a comprehensive tool, but I wouldn't put my money on a single tool to be able to provide the level of information that a CGA can provide.
Well, thank you both very much for the really interesting presentation.
Thank you.
Well, sorry?
Thank you so much.
I have the Asian brown.
She's still hypertensive, like 190. Sorry? Okay, yeah.
Is there anything else?
No, her weakness is improving. I was thinking about no, we'll keep her inpatient for a PT.
Yeah, let's let PT clear her.
Sorry?
Let's let PT clear her.
Otherwise, she's clinically okay.
Yeah.
Okay. Just the hypertension piece.
Okay.
And you're not doing lower extremity, right?
Yeah. There was a study, I can't remember, from Haldol. In the year Haldol preemptively. And I think that one study did show that there was possibly a reduction, but again, like it was one study and one subject population, I can't remember.
Yeah.
So like, not routine, but still in the study.
Yeah, just like sometimes you're like,
They're already delirious, yeah.
now they
100%.
must have to have
Yeah.
surgery.
Yeah.
And then you're like, well, they're gonna be delirious.
Yeah, that's what I just quote. Like I saw a patient earlier this week who was delirious. We were referred for perioperative, and I was like, they are at high risk of ongoing delirium, progressive worsening of their delirium with this stress. Like they're just gonna take another hit.
Yeah.
But I don't.
So it's like, I don't know if it's worth trying something. I was just wondering if, I know there was a time where we were just prescribing something to give them that, well, give them that's the week of just giving them 1 day. Reduce the risk of ongoing delirium or the duration of delirium.
Yeah, but not by a lot.
Yeah, no,
like whether
so
it's clinically or statistically relevant is the hardest part.
Yeah, so just trying to figure, okay, I was wondering